which is kind of initiated by National Association of Professional Social Workers in India. So they invited us to, join hands with them and conduct some awareness events, activities. So as part of that, the Department of Social Health Innovation at the Prasanna School of Public Health, we are conducting 4 different activities, and one of these is this webinar on the topic "You Are Not Alone: A Conversation on Hope and Healing," mainly the role of mental health professionals in suicide prevention. We cannot get a better person than Dr. Anish. He's the stalwart in suicide prevention, internationally renowned mental health professional. And so immediately when we invited him, he immediately agreed to be here to give the talk. So thank you very much, Dr. Anish, for being here and willing to share your thoughts and insights in this area. And without taking much time, I invite, of course, the flow of this webinar will go like this. So there'll be an introduction by, our colleague, Dr. Desma. Followed by that, Dr. Anish will, give his talk. Followed by that, we will have question and answers. Which will be moderated by Desma. Okay, and then we will close with thanks. All right. So with that, I invite Desma to introduce Dr. Anish.
Thank you, Dr. Teddy. Good evening, everybody. We are truly privileged to have with us today Dr. Dr. Anish V. Cherian, whose work has touched so many lives and continues to shape the field of mental health and suicide prevention. Dr. Anish V. Cherian is an additional professor of psychiatric social work and leads the NSPRITE, NIMHANS Suicide Prevention, Research, Implementation, Training and Engagement Center at the National Institute of Mental Health and Neurosciences, NIMHANS, Bangalore, India. He holds a PhD from NIMHANS and a Fogarty postdoctoral fellowship from the University of Florida, USA. He is the elected national representative of India from the years 2024 to 27 and the co-coordinator for the Partnership of Life in the Southeast Asian region of the International Association for Suicide Prevention. His research interests include global mental health, self-harm and suicide prevention, and stigma. Dr. Anish V. Cherian was awarded the Public Health Research Initiative Fellowship by the Public Health Foundation of India in collaboration with the Science and Engineering Research Board to conduct public mental health research from the years 2015 to 19. He served in the topic expert group for the World Health Organization's Mental Health Gap Guideline Update in 2021. He is also a member of the Institute Human Ethics Committee of the Indian Institute of Science, Bangalore, and NIMHANS. He has participated in the Indigo Network and Indigo Partnership, contributing to a Medical Research Council, UK-funded multi-country study on stigma. As the lead investigator, he directs multiple suicide prevention projects funded by the Wellcome Trust, DBT India Alliance, for establishing a self-harm registry and health system strengthening, ICMR for developing a mobile app, the Ministry of Health and Family Welfare, Government of India, for developing hospital-based surveillance of self-harm, TVS Motor Company Limited and Tata Electronics Private Limited for workplace suicide prevention, the Himalaya Wellness Company for community surveillance of suicidality, and the Indira Foundation for a youth suicide prevention initiative. He has supervised 12 doctoral scholars in public mental health and suicide prevention. With such an outstanding body of work and dedication to advancing mental health and suicide prevention, it is our privilege to have Dr. Anish V. Cherian with us today. A warm welcome to you, sir.
Thank you so much. Thank you for the warm welcome and the introduction. Thank you, Dr. Teddy and Dr. Lena, for the invitation. And I think one line is the introduction is like I'm also from that part of the world. I'm a Bangalorean, so it's a kind of a home for me. So thanks, Teddy, for the invitation. Thanks everyone in the evening. So it's a late evening. 5 to 6 is a late evening, a very personal time for all of you. But I think you are chosen to be stayed back to listen to a very important topic, suicide prevention, which is very, very important, at least in our generation. So what I thought I'll introduce the suicide prevention and role of social workers and other mental health professionals, and what we initiated in as part of the NSPRIDE, these three sections. So as we all aware, the suicide is the a major public health concern. Every 40 seconds we lose a life. It's about 8 lakhs per annum globally. But I think it will be beyond, because it's all reported suicides are very less. We might have lot unreported suicide, but as per the WHO reports, it's close to 8 lakhs every year. And if you look at each suicide attempt, completed suicide, there will be at least 20 or higher suicide attempts. And as we all know, this is the third leading cause, especially younger people below 24. And we also know most of the suicide, especially 75% of the suicide globally, reports from low income countries, especially country like ours in China. If you look at Indian data, we have a body called NCRB, National Crime Report Bureau, where suicides are reported. As per 2022, we have around 170,000 suicides, of which around 40% or more are very young people, like less than 29. And if you look at the national data, around 50% of the suicides are reported from southern states like Karnataka, Kerala, Tamil Nadu, Maharashtra, and other closer states. And if you look at the national rate, it's about 12 per 100,000, 1 lakh population. If you look at Karnataka, we have lost around 13,000 people for suicide in 2022. That's slightly almost double the average of national average. National average is 12. We have around 20.3 per 1 lakh population. And if you look at the Sikkim and other northeastern states and the Union Territory, the number might be very less, but the rate is quite high. It's about 43 per 1 lakh population. And if you look at the right side graph, there is an increase. We had actually did a systematic review recently. We looked at data for last 10 years. There is a steady increase in suicide death in India. So suicide is not just a loss of a life, but at the same time, it has a huge impact on personal, social, and even the economical part of the country. So if you look at personal loss is a human loss. At the same time, it induces a lot of mental health and trauma, and it has a huge stigma as well. And it also impacts the peers, community, and it also has a huge cultural consequences. I was actually reading a recent article on Lancet, which says the loss productivity or the economic burden of suicide on our GDP. It's quite huge. It's also even the suicide attempts also, it also has a impact on the growth of the country. And if you look at the emergency admissions, it has a huge cost on the healthcare as well. So there is a huge challenge. I mean, at the same time, we know suicide is a preventable thing, but at the same time, there are huge challenges in having suicide prevention. As we all know, there is a huge stigma or taboo linked to suicide, mental health in general, but suicide in particular, to intervene, especially family honors, and stigma is I mean, especially suicide stigma is quite high, because many of the time, like when we ask the patients who comes to hospital, why didn't you come, I mean, like, why didn't you reach out, I mean, the fear of stigma, like how others will feel. So they could have actually come, but at this, they reach hospital only for medical attention, not for any psychological help. And we did a couple of surveys among young people. There is a huge taboo in open discussion. In a large sample of 8,000 people, we realized only 15 or 20% of the people disclosed that they had emotional distress. They don't share. They it hinders them to share because the people might feel why if in case if I share my thoughts, share my feelings, how others will consider me, how ill treat me. And that's the reason it denies, I mean, it kind of hinders them to discuss or share their distress. Again, another major factor is lack of awareness. There is a limited public understanding about the supports available. We also again we did a survey in Mangalore, some of the colleges in Mangalore, a couple of years back. Less than 20% of the people knew what are the crisis helplines available. If I have a emotional distress, most of the time young people doesn't know where to go, whom to reach, where the helps are available. Then we looked at what are the risk factors. This is part of our larger sample, which I'll present a bit later, the data. But we looked at what are the risk factors in youth. One of the major risk factor in youth is previous attempt, self-harm or any kind of attempts, even self-harm or suicide attempts. Mental conditions like especially depression and schizophrenia or other mental conditions. Social isolation, substance use. We have seen there is an increase in substance use, especially one of your own PhD scholar has actually published recently one article. He has seen young people's the increase in substance use, especially all forms of substance use, gambling, relationship issues, access to lethal means. The means means availability of the means at home or in the nearby places. Most of the time, most of our patients who comes to emergency department, they would have overdosed. The pharmacy will give you any kind of medicines without prescription. So that actually makes people vulnerable. Another major issue we also faced or identifies the unsafe media portrayal of suicide. Most of the newspapers, they portray suicide as a very glorified manner. Though there is a guidelines, there is a WHO guidelines, there is a PCI guidelines. But the portrayal of suicide is quite very unsafe and glorified way. And as we all know, any illness, especially adverse childhood experiences, have an impact on growth of the children and impact on their mental health, including any mental health disorders, especially suicide. And bullying, as we know, younger people, even now, the recent days, I think we have a lot of reports coming of even the cyberbullying. And the other factor is families to suicide. There is a high chance of family history. There is a chance that the younger people also will attempt or end their life by suicide. And family and IPR issues, family or peer conflicts. These are the major risk factors we identified. Why I'm brought this here, because I think when you identify these kind of risk factors, it's okay to ask or establish a contact and move further and help them to take help. Can we save a life? Yes or no? It's yes. But how? Reaching out to the people. That's what I thought. Like I was very particularly interested in talking to young people, because this is a population where we are having an issue. At the same time, this is the group where we can actually encourage to help the young people. One is reach out. Most of the time, what we have realized and we understood was like most of the time they won't seek help. Even if they are in distress, most likely they will stay away or isolated. When young people are isolated or if they are not reaching out, if you feel that that person is not okay, it's okay to ask, how are you? Are you okay? If they start saying something, listen to them. Most of the time, they are not heard. They are not listened to. Understand them. Don't be judgmental. Don't blame them. Understand them. Most of the time, like we feel it's very silly. They're talking very silly. But at the same time, understand them. Be empathetic to them and listen to them. And at the same time, refer them. Most of the time, many of them requires psychological help or counseling help. They will be feeling helpless, but they won't ask for help. So talk to them, refer them. And education, that's the most important. I mean, I always encourage this part, especially the students, social work students. We need to beyond clinical, beyond the NGOs, organizations. We need to educate people, public. We have a particularly social work and public health professionals. We have a huge responsibility on educating people to reduce stigma. I also thought maybe I think these are the awareness campaigns, but at the same time, as a social workers, we also have a huge responsibilities. Most of the time, we end up become mental health professionals and we end up doing only the clinical work. So we need to expand our horizon. We have to expand our workspace beyond the clinicals. As a social workers, we should, especially country like ours, where we lose lot and lot of people for suicide. As per the reported documents, we lose at least one person at every 3 minutes in India. That's as per the reported reports from NCRB. However, it will be way beyond. Therefore, as the social workers or the public health professionals or the mental health professionals, we have a huge responsibility in suicide prevention, especially capacity building, community engagement, advocacy, public awareness, and research. This is the component we thought we should get involved beyond just hospital work or the clinical work or whatever we do, because it's a large social issue. Society it's not just a health issue or a mental health issue. It's a large public health issue where we're losing a lot and lot of people. So what we can start with is like we can initiate mental health literacy programs. Fortunately there is a PhD scholars in your own department where he is actually initiating mental health literacy training program for the students and the faculties in the institute, where it's developing module. We need to get involved in such mental health literacy training programs, especially for the general public, healthcare providers, and educators, teachers, anyone and everyone who you think are important in the, especially in the suicide prevention domain. Specialized training programs like brief interventions or CBT for suicide preventions. We need to get involved in specialized training programs for healthcare providers, teachers, community leaders, uh, especially in identifying, referring, and providing interventions. We also should get involved in school-based programs where earlier I think when we were in school we had a lot of life skill education programs. or value education programs. These days, I think we are losing out and we are getting into a lot of academic oriented courses where we need to integrate and equip school and college professionals in especially providing emotional resilience and early identification, warning signs, and early identification and intervention programs. We also should engage in community engagement programs where we have a huge response, as I mentioned, stigma reduction campaigns, community workshops, suicide prevention gatekeeper training programs. That's another very important task where we generate or train lot and lot gatekeepers in the community where they can actually recognize the warning signs and refer. Maybe I think they can even train into providing interventions at their doorsteps. One of the other areas which we actually mostly ignore is a postvention. Families of who bereaved, who died by suicide. There are literatures emerging globally now. If a person dies by suicide, there is a high chance that the families and the close near one will have a similar feeling or they also attempt or end by suicide. The impact of one person's suicide will have at least 6 to 135 people. So there is a huge responsibility as a social workers or a person from the community to help the families who lost their loved ones. We also should strengthen the health systems where at the moment most of the hospital where we cater to, that we don't have a screening system or we don't do an early identification or there is less intervention provided. As a social workers, we should be trained in development, especially administering various tools in identifying, because most of the time we will be in hospitals, we'll be in different clinical settings where generally we ignore suicide attempts and suicide thoughts or ideas of this, and so we don't check on suicides. So especially in the emergency departments, we need to establish a protocol where emergency the people who are actually attempted or people who are actually self-harmed who comes to how do we provide intervention for them. It should be very comprehensive one, so we need to be trained. I encourage social work students, especially in the especially in the second year students, who can actually take up some of the cases, who can actually provide intervention to them, and equip yourself. And another area is the follow-up and care. I'll come to the data a little later, but I think what we have realized and what we have identified is when we provide intervention to the self-harm or suicide attempt cases, the reattempt rates comes down. So the most of the time when they come to hospital with a self-harm or suicide attempt, they don't receive any intervention. We need to promote continued care and intervention to reduce reattempts, which is possible and which can be part of our curriculum in social work education. And other area is technology and sorry, I think other areas, technology and digital interventions, especially tele-related helps, like for example, things like telemanas, or each institutions or departments, especially our departments also can have a helpline where we can actually provide immediate support to the people who are actually in need. And online resources where provide digital tools, resources, and training modules for wider reach, especially social media and other platforms we can use to reach to the people and educate people about suicide and suicide prevention. And we can also development of mobile application, especially health is becoming more and more popular. So that's another area we should get involved in. Research and data collections. So the most of the time, what happens is we do not have much data on self-harm or suicide. What we I mean, for example, if you take our example, like, India doesn't have a data on self-harm. What we have is suicide death data from NCRB. So if you all get involved in creating database on suicide, self-harm, it will help us to develop targeted interventions and different strategies, because what we do not have much data. So which helps us in use the data to identify high risk groups, especially younger groups. Within younger groups, like if you, our own data shows like young women groups or young girls who are at risk. So we can actually have a target interventions. So if you, all these data will help us to develop the target interventions. And we should also have a support for ongoing research support, because I think most of the time what we do is like we will have a cross-sectional research and we'll end up there, but I think we need to have a ongoing and continued research and planning. Another major area where social workers need to intervene or involve is the policy and advocacy initiatives, working with medias, especially training media professionals in responsible media reporting, working with NGOs and organizations, collaborating with the various community-based organizations, working with government departments, schools, colleges, or departments of Panchayat Raj or health to help them to frame effective policies. Now, I also move on to some of the evidences. I have been talking about various strategies, or maybe some of the this. I also want to share some of the evidences from our own initiatives, what we thought will be useful. So, what we initiated first was established a self-harm registry in some of the hospitals in Karnataka. We have around 16 hospitals in different district hospitals across Karnataka. Over the last 2 years, we have more than 20,000 cases with self-suicide attempts coming to emergency departments. We could actually help provide intervention for 14,000 odd patients. And we also realized many of them we could not even reach. More than 1,400 cases were broad dead cases. We could have actually, if we had a very good community support or community interventions, we could have actually saved this life. But we could actually, if you look at the global literature, the reattempt rate is about 22-23%. If you provide intervention, the reattempt rate is around 4 to 5%. In our population, fortunately, we could actually bring down the reattempt rate to less than 1%. Among 765 people who actually received intervention, 200 people had actually reattempted, and we lost around 35 people. That's less than 1%. This is one of the major work what we thought was very important, because we didn't had a self-harm dead at all. This actually brought us a lot of insight, where we know now at least lot cases are coming to hospital. If you provide intervention, we could actually save life. Another intervention, what we thought was uh, uh, among this 20,000 people, large majority of them were young people. Around 45 to 46% were less than 24. So we started thinking like what else we can do. So if the people who are coming to hospital are the people who are actually have a significant medical condition, or the attempt is so fatal where they need medical treatment. But large majority of the young people will be other large group will be, they be either working or in colleges. That is where we initiated two programs where we thought we can actually reach to the young people, whether in the workplace or in the school or other places. So this workplace suicide prevention initiative, we call it as Empower and Promote. Now we have around catering to more than 1 lakh population, young people, most of them very young people, like less than the age group between 18 and 24 or 25. We have around 43 mental professionals. Most of them are social work students. We try to integrate mental health in service, mental health services in workplaces. We took a well-being approach. We didn't go through a suicide prevention alone, but at the we thought like we'll have a broad well-being approach. We provide mental support to the employees. We also started capacity building within the system. We have a suicide prevention action team in each departments there. So where there will be some 30 to 40 people who are actually trained as a suicide prevention action team, who can actually identify. They are almost like a gatekeepers who identifies and who provides intervention, who refers the cases to the workplace, the clinic what we have in the workplace. And we also have a peer network, and we also closely work with the administration, so that I think we can actually provide better treatment and support to the employees as well, who actually need support. And in overall, if you look at it helps to foster the mental health, and we focus on stress reduction and work-life balance. Another program is, as I said, is a community-based program where we call it as Suraksha. It's a broad approach where we are trying to cover the entire population, especially young people, collaborating with various departments: health, education, family welfare, panchayat raj, across all the departments, so that we can actually cater to everyone in the community. One is the workplace. This Suraksha involves the workplace, schools, colleges, each and everyone in the community. It's a multi-sectoral collaborative program where formal, informal sectors, government sectors, health providers coming together to save life. And we also, as part of the program, we thought we should have sustain and continued support and training. We established a center where we'll have a lot of professional development. We have a regular training programs. For example, we have every third week and the third week of every third Saturday and the first Saturday we have online training program and in-person training programs where for everyone who wants to be gatekeeper. We'll also have regular training on advanced training on suicide prevention for mental health professionals and others, and school teachers and other people who are interested in. We'll also try to get more and more funding, so that I think we can actually establish suicide prevention initiatives across. So though we initiated with this small 5 hospitals, now we have across 16 hospitals. different workplaces. We have around 6 or 7 work sites range in different 4 or 5 states across India. We also establish self-harm registries in different hospitals where the social workers or psychologists who identifies and provides interventions and take care of them. For almost now, we initiated with 6 months. Now we have following up for almost 24 months to 36 months. In conclusion, I will say, in our experience with working with so many people, we realized suicide is preventable, and each suicide attempt is a cry for help. And we also realized nobody wants to die. At the same time, they want to end the distress, where we all should get involved. Suicide prevention is every single individual's business. We need to spread the awareness. We should encourage people to get suicide literacy so that I can actually save more and more life, and to say every action counts. Let be the change agent. Thank you all.
Wonderful, Dr. Anish. And yeah, thank you very much for such a insightful talk. Definitely, of course, I learned so much from this, from your talk. So probably, yes, I invite the participants to post your questions if you want to post in the question and answers or chats. Yeah, so I would invite the students to put their questions either in chat box, or you can also raise your hand, and then I will invite you to pose your question. Okay, so probably till the students prepare their questions. Dr. Anish, yeah, of course, you have extensive work experience at international multilateral organization level and with the government, and of course with a lot of community work. So being a professional in this space of suicide prevention, what would be your advice to, of course, you gave a lot of advices, okay, mainly when you work with the government, what challenges you faced, and how our public health and social work graduates need to be prepared for that?
Yeah, thank you, Teddy. I think it's a very important question, and suicide is, especially in the area of suicide prevention, or any other area. Working with what approach we took was, suicide is a social issue. So everybody in the system, or everybody has a role to play. That is where, for example, the community-based initiative, what we Suraksha program. So we worked with the state government. So, for example, typically I should work with the health department, but I think we initiated through Panchayat Raj department, where we went with the panchayat. So, but health is as a part of it. Education, involve everyone. Everyone make them as a partners in the your initiatives. So they share, for example, the work happening in Ramnagara. That's as a where I don't have to be there now. It's a self-sustained, and it's part of the government system. So they run the show, and we have our staff for 3 or 4 staff there. But the entire system is in place. Where involve them, make them feel, convince them that it's a very important topic, or it's a very important issue to be taken. Their role as a for example, you work with the civil servants, or IAS officers, or the district collector. How his role is so important in implementing this. from there to teachers. For example, most of our work involves ashas, Anganwadi workers. Very recently, we trained around 700 police officers, police constables as a gatekeepers. They said they also taught us various lessons. For example, if a domestic case comes to the police station, the police take the cases and send them. But at the same time, they can start counseling them, or maybe I think they can provide services there itself. So they thought, okay, yes, I'm doing something, you know. So involve them and give the credits to them. So involve, and they are the partners. You need to be, it's more of a, like, collaborative approach. It's not there is no hierarchy or anything. It's more of a collaborative thing. That's the approach I take generally.
Okay. Thank you very much, Dr. Anish. Um, Dear participants, any questions? Yeah, there is a question. Let me read. There is Jeffrey Sampson, first year MSW student. How do feelings of hopelessness differ from clinical depression? And how can we recognize when normal sadness turns into a warning sign?
Thank you very much, Jeffrey. I think I should have actually had one line, but I think I should have actually explained it earlier. So what we realized and what we understood with our larger population, we intervened around 14,000 people. Very less people had mental health conditions. Most of them had psychological issues, or maybe things like distress and all those things. So they might be distressed. I'm feeling sad. But to qualify for the clinical depression, you have a criteria where you have, among the college students in Karnataka, Mangalore, we had around 24% of the population said they're psychological distress. They're distressed. And the providing intervention for them was easier for us. And if Jeffrey, if you feel someone is not okay, you just ask them, how are you? Most of us don't even wish, or not even ask, even like, I think whenever we see each other, like we wish and we ask, how are you? Most of the time we just ignore that now. These days we don't even ask that. And we also did one another work with the IT professionals, where we asked them, why people don't intervene when I don't know how to ask, how to, if I feel, if I ask that question, if I say something, I don't know how to intervene. That's the reason I think when we feel that person is not okay, you just ask him. If you're not able to intervene, just refer to the clinic, someone who can actually intervene. Maybe I think psychologists or social workers or the psychiatrists, whoever is mental professional is. Yeah, thank you.
Thank you, Dr. Anish. And of course, also a little bit connected to that is the next question from Madeline, second year MSW. What are some warning signs that are often overlooked in someone who may be struggling with suicidal thoughts?
Thank you. It's also a very important question. Most of the time, literature says, and our own experience, many people, most of them have some exhibit some warning signs. And I'll give an example. One student, a couple of years back, when 5-6 years back, he came to my room. He's from very humble background. He came to me, and another student was also sitting, and he came. He started thanking me, and he was well dressed. But I think I was very happy for him because he was well dressed and all those things. But I knew his background. But I didn't realize. I felt very happy about him, and he was thanking, and for not much obvious reason why he has to thank me that time, because there was nothing. He was not finished his course or anything. But other student felt, sir, I think something is wrong. Then this boy goes to the other room, other faculty's room, and he does the same thing. Then we called him. So then what happened? Then we asked what happened, how are you, and all those things. Then he said he's going through a very difficult situation, and he even planned his everything, like, this Saturday I will end my life, and what will be the method, where everything. Fortunately, but we asked that question. Uh, then we took him to hospital, and I mean the rest is like we could actually help him, and he's I mean I see him every day these days. I think I'm happy to see that. At the same time, these are the warning signs, but we generally ignore. If you feel someone is not okay, sometimes not necessarily all the time depressed. I mean, like if you are distressed, you don't necessarily exhibit like very low or isolated. Sometimes they will be very cheerful. Is there any change in the behavior, whether the positive side or the negative side? Just ask them, how are you, or is it everything is okay? Most of the time we just overlook many of these kind of things which we think, because okay, he came with happiness, and I just, I was very happy, and we end there. It's okay to ask. Yeah, thank you.
Yeah. Thank you, Dr. Anish. And of course, there are a few other questions, but there is one student from hospital administration.
Yeah.
I will go with that. And then, of course, I'll hold social work students' questions for a while. Um, how can we as individuals support the hospital efforts in suicide prevention?
Sorry, hospital efforts, is it?
Yeah, how can we as individuals support the hospital efforts in suicide prevention?
Yeah, thank you so much. I think one of our work was the initial work was that hospital. So when I'll give an example, I'll go with my journey, so I'll connect easily there. So we wanted to start a self harm registry. I sent an application, I mean proposal to the government. So it took 3 years for us to get the funding. And as a researcher, I went to hospital. I mean, my staff went to hospital with the thinking that the number of cases will be like less. Our sample size was 365. So the staff goes there. First day we got 14 cases. So the 365 from 5 hospitals, but in one hospital we got 500 in first month itself, and we had 5,000 cases. Then we realized, I think it's beyond one project staff or these things. But then we thought we should train all the healthcare providers. Most of the time, even if it's a mental professional, social workers, psychologists, or any healthcare providers, we are not trained in suicide prevention or providing interventions for people who are self-harmed or suicide attempted. So what we initiated is we made a good self-harm registry. We also started self-harm suicide brief intervention for people who are attempted. We also initiated training programs for emergency department staffs and other people who are actually working directly with suicide attempt cases. Now, for example, in Suraksha, we have all the primary health centers in Ramnagar has our self-harm registry. Who reaches to primary health center with any distress will reach us now. So one is training. Second, having a database there, and having qualified or maybe I think trained mental professionals in these places plays a huge role where we can actually reach to the large majority, because most of the time they won't come to mental health settings. They most of the time the people who are actually attempted or self-harm will reach healthcare general hospitals or primary health centers or clinics. Thank
Yeah.
you. Yeah.
Thank you very much, Dr. Anish. And then there is one more question from. I mean, there are more questions. There's one from a public health student named Anudeep. Sir, does social media influence the suicidal thoughts among the young adults? And if so, what could be the possible interventions in such cases?
Yeah. Yeah. So, social media portrayal, I think I covered a bit there, but at the same time, social media is one area where we don't have any much hold. But portrayal of suicide in print media or social media or any of this thing is quite this. We have a guidelines on suicide reporting. We have a clear-cut guidelines on suicide. Unfortunately, I think it's not taught in many of the journalism courses or anywhere. Like nobody is aware of it. But what we can actually encourage as a mental health professionals or public health professionals or social workers, this social media is a good platform for us to intervene. We can actually generate awareness. And now one of our student was actually looking at status, how people put their status based, I mean, like which to communicate their feelings. We can identify from there. And we can actually use this as an interventional platform where we can actually provide intervention as well. So, but there should be large research and training has to happen. But I think it's a good platform for or a future that will the future for especially young people. We have a very small work on social media interventions. Especially we have a program called YESHAS. That's a young youth mental health and self harm study, where we are trying to have video-based or short reels for suicide literacy and suicide training programs. But it will be a good platform. Thanks for the question. Yeah.
Yeah, thank you, Dr. Anish. There are a few other questions. Probably I'll just take one and then we'll close. Yeah, there are a little bit technical questions. Probably, yes, Dr. Anish, if it's okay with you, I will send some of these questions and then probably through audio message or probably writing you can share with us if that's okay with you. I think, yeah, I will go with this last. Yes, I think there's one more student from MPH named Meenakshi. We often talk about spotting warning signs, but what about the silent sufferers who did not show any? How can we reach them?
Yeah, thank you, Meenakshi. I think it's very important question. Like we always say that I think warning signs who actually vocal about their symptoms and come out, but at the same time there are a lot of people who actually silently suffer. But our understanding, our research or our interaction with so many people, we realize nobody wants to die. They just want to end their pain. Stigma or I don't know where to go. Sometimes we ask these questions to, I can share our article. I think we asked many young people, why are you not actually seeking help? Most of the time, I don't know where to go. I don't know where to ask. And I'm not very clear. I don't know if I say my feelings to them. I don't know how they react. That actually hinders. By educating and spreading the awareness, like these are the available resources, or maybe I think you can call is a helpline like Telemanas. You can encourage people to call, so they will call. and we initiated some program, a college or a university campus-based program in IAS, in Institute of Sciences. I'm part of the well-being there. So we realized lot and lot people who walk into the clinic, the helpline services are utilized properly. Even our empower and promote, that is where we thought we will integrate mental health in the workplace itself. They don't have to come to demands, or they don't have to come to extreme, but the help is available there. When the help is available, and I'm aware that there is a help, people will go. And 70 to 80% of the people, they just seek help. I think the international literature says 77% of the people suicide is preventable. Only very few people are impulsive and they won't reach out. But large majority of them will reach out. The silent sufferers, I think if you have an awareness, you know where to go, they'll reach out. Thank you, Meenakshi. It's a very important question. I think we always think that people, but at the same time, our research and our interaction with various people think other way. Like, people will reach out. Even, for example, our own intervention program, the initial program was 6 months. We called after the intervention, we had repeated calls to the patients for up to 6 months. But we had calls from the patients on 7th month, 8th month, asking them, you are the only people who used to call us. Why are you not calling now? So we had to extend our call to 9 months, then to 12 months, then to 18 months, to 24 months. Now we are planning to 36 months, and maybe I think it will end up 5 years. Yeah, thank you.
Yeah, thank you, Dr. Anish. So, of course, thank you for your patient answering the questions posed by the students. Definitely, I will compile the rest of the questions and share with you for your responses. And so with that, we've come to the end of the webinar, and I invite Professor Lina Ashok to give the word of thanks.
Very good evening to everyone. And thank you very much, Dr. Anish, for your valuable time. And we know your passion and the work that you've been doing, great work that you've been doing in the last few years. We have also reached not only international to the national, but to the international level. Yes, we are very proud of you and your work. And we are glad that we're also working with you, some of our PhD scholars. Yeah. So we really want to take this forward. And I think you very clearly also told us about the role of various health professionals, the mental health professionals, also including the public health professionals, and what we need to do. I'm glad that students also posted good number of questions. Thank you, dear students, and we will take this forward. I think we will have some similar webinar even, for the Prevention Day, Suicide Prevention Day, which is soon coming on the 10th of September. So on behalf of my team, Dr. Teddy Andrews, my colleagues, and my director, the Prasanna School of Public Health, and all the other HODs and my colleagues from the entire school, thank you very much, Dr. Anish.
Thank you so much, ma'am. Yeah, thank you. It's always a pleasure. Thank you so much, ma'am.
Yeah, thank you very much, Dr. Anish, and thank you very much, students and other colleagues and faculties who joined us. Yeah, so definitely you can look out for a follow-up session probably on the International Suicide Prevention Day coming up next month. Have a nice evening, all of you. Dr. Anish, I'll speak to you later over phone.
Sure. Thank you so much. Thank you all. Thank you.
Have a good evening. Thank you. Thank you.